All right. I think we can probably get started just so we give you the full hour, Dr. Fang. So welcome, everybody. I know we'll have more people join us, but I want to make sure we start on time. For those who don't know me, my name is Tess King. I'm one of the inpatient chief residents here at University of Washington. It's great to have you all here. As with our other Grand Rounds talks, please do feel free to enter into the chat any questions you have or comments and feedback throughout the talk. And then at the end, I will be helping moderate the question and answer. And to get us started, I want to first welcome Dr. Rob McClellan, who's the director of the UW Heart Institute and also the division head of cardiology here at UW. And I know he's going to introduce our lecture today and our speaker. So Dr. McClellan, thanks for being here.
Thank you very much. I am going to introduce Jim in just a sec, but before I start, I wanted to just acknowledge Werner and Joan Sampson, who this lecture is named after. I see Werner has signed on to the Zoom again, so he's checking up on you, Jim. But Werner started here at the University of Washington over 60 years ago. He was one of the two original cardiologists hired by Bob Bruce. After Bob Bruce came here, it was Len Cobb and Werner, and he has held various roles through that time. He's also been an associate dean for admissions, so many of the faculty at UW can remember, maybe not so fondly, their interview with Werner to get into medical school, but he's been such a fixture here in the school and in the division, and I just want to thank him and Joan for their sponsorship of this lecture. I'm only sorry that it couldn't be in person, Jim, and we could wine and dine you appropriately, but thank you for joining us. I'm going to introduce Jim Fang, who I've known for a while now, and I'll just say he is an incredibly accomplished cardiologist, but that's not why I hang out with him at dinners or meetings. It's because he's got a great sense of humor, which I think you'll see from his sort of lecture. He's the chief of the Division of Cardiology at the University of Utah and the executive director of their cardiovascular service. He also holds the John and June B. Hartman Presidential Endowed Chair there. Jim is really internationally known as an expert in heart failure and is on the editorial board of almost all of our major journals. He's won many teaching awards, including the Laennec Master Clinician Award from the American Heart Association, which is given yearly to recognize a lifetime of achievement in clinical care and teaching. He's the author of over 150 manuscripts, multiple editorials and book chapters, and 11 different guidelines. He is also one of the co-authors of the current new heart failure guidelines that are going to come out this spring. And although he's sworn to secrecy about them, I think you'll get a flavor from his talk about what the new guidelines, particularly around HFpEF, are going to look like. And I'll just say this issue of HFpEF and how to treat it, after being really stagnant for, I would say, decades, is really sort of heating up, and we are actually making some progress. So I'm really glad that Jim is going to talk about it today and share the sort of state of the art. So thank you, Jim, for joining us.
Rob, thank you for that overly generous introduction. And I too would like to thank Dr. Sampson and his wife for supporting this lectureship. These are incredibly important activities to maintain the academic tradition and spirit of academic medical centers. So let me see if I can share my slides here. So hopefully over the next 45, 50 minutes, I'll be able to shed some light on this really challenging topic that everybody in the call has encountered, and perhaps give you my personal take on it, which may resonate and may not resonate with some of you, but here we go. So here are my disclosures. Importantly, I think it's important to point out that I do have roles in sacubitril valsartan, as well as dapagliflozin in clinical trials, having served on steering committees and executive committees for these studies. So heart failure with preserved ejection fraction is a big problem. It represents 50% of all patients admitted with heart failure. It appears to be increasing in prevalence. As Dr. McClellan outlined, treatments have been very challenging. Our population is aging, and it disproportionately affects those of an older age. Diagnosis turns out to be a little trickier than I think it's often made out to be, and this has also impacted sometimes the interpretation of clinical trials in this space. And then finally, it's important to recognize that this condition, despite the preservation of the ejection fraction, is highly morbid and mortal. And this is, I think, an appreciation that has evolved over the past few decades. So we have tried, though. There has been a lot of effort to try to figure out how we can improve the outcomes of patients suffering from this condition, heart failure with preserved ejection fraction, previously known, by the way, as diastolic heart failure. We could talk a little bit later about why we've lost that moniker, but suffice it to say that we have been trying to fix this problem for a while. This is a summary slide of the last 20 years of clinical trials in this space using a number of strategies, as outlined by the color coding over a number of prospective randomized studies. And as you can see, soberly, most of these trials have either been neutral or in some instances even caused harm. Now, there have been, as also Dr. McClellan alluded to, been a explosion, frankly, of new approaches. Most of these have not worked out, but I will try to, in my talk, highlight a number of the things that I do think that have worked, but perhaps surprise you with how I think they are working. The latest casualty, for lack of a better word to put it, is this idea, which was to relieve left atrial hypertension and dyspnea related to left atrial hypertension producing dyspnea by providing a pop-off valve, by literally putting a hole in the atrial septum to decompress the left atrium into the right atrium without excessive shunting. And this particular enterprise, which was reported last week, noted, perhaps it's no surprise, that that doesn't appear to work. But perhaps it speaks to the desperation of our field about trying to do something that would help these poor patients. And the community of experts have continued to struggle with this. What I'm going to show you over the next two slides are the current guidelines as they stand. Dr. McClellan also alluded to the fact that early April, the new ACC, AHA, and Heart Failure Society heart failure guidelines will be released. And despite our very nervous anticipation for that, up till now, we've not had a lot to say. So what I show you here is a small table of the recommendations for symptomatic HFpEF, and I'd like you to concentrate on rows 2, and then the second column. In the last column, you'll see the level of evidence to support these recommendations are unfortunately primarily are supported by expert opinion rather than evidence. And that in the last column, you can see that at least in this 27 update, these recommendations were simply cut and pasted. There were a couple of additions. These were not huge game changers. You'll see that the use of an MRA was given a 2B recommendation, which was frankly the weakest level of recommendation the guideline committee can give for clinical practice. The idea that we should not be using nitrates in HFpEF is, I think, important to highlight as causing actually harm and certainly no benefit. And so that might be something to take away from this talk, is that if you're using nitrates to improve outcomes in HFpEF, you're probably skating on thin ice. Well, the obvious question that comes up is that despite decades of trying, why have we gotten nowhere? Well, it's certainly possible that we've been studying the wrong patients. It's certainly possible that early trials were putting people who were short of breath into the trials that had actually shortness of breath that was either multifactorial or non-cardiovascular in origin. Number two, maybe we've been too focused on this phrase heart failure, and for all of us, heart failure is just synonymous with neurohormonal activation, and therefore antagonism should be central. But that hasn't really been borne out. Number three, maybe we are looking at the wrong endpoints. It's a patient once said to me, when we were talking about clinical trials, and trying to convey in a clinic setting why we recommend a drug, she said, well, what is the difference to her between all-cause mortality and cardiovascular mortality? She said to me, that isn't being dead? And so, I think these are really relevant questions for clinical trialists as we try to impact patients' lives. But importantly, I think it's time to rethink what we're actually trying to focus on. Is it really the heart that we're focusing on? Or perhaps there's another organ or another way to think about this that might help to enlighten us and perhaps therefore improve the outcomes of these patients. So a number of years ago, now this is almost 10 years ago, I think most clinicians had already embraced this, but Sanjeev Shah at Northwestern really put pen to paper and used machine learning applied to a very deeply phenotyped cohort of almost 600 patients to explore whether or not he could tease out the heterogeneity of HFpEF rather than us trying to embrace homogeneity. And in this particular study that was reported in Circulation, he was able, through machine learning techniques, to divide his cohort in an unbiased way into 3 groups, all of which had different outcomes and which were all characterized at the bedside by different characteristics. And this approach continues to be embraced, that not all HFpEF is the same. And what you should be doing as a clinician is to figure out what subtype of HFpEF you have and then treat appropriately. Well, one comorbidity that characterizes a significant proportion of HFpEF patients are those patients with diabetes. And this is work from Tom Hanf in collaboration with Julio Chirinos and Tom Coppola at Penn using the Penn Heart Study and the TOPCAT data sets. Took a proteomic approach and were able to demonstrate that a apolipoprotein, specifically ApoM, appeared to be the mediator of the HFpEF outcomes when HFpEF patients had diabetes as a specific subtype. And, is ApoM targetable? We'll see. But again, this approach of embracing heterogeneity and pursuing particular subtypes of HFpEF does appear to be not only sexy in current clinical investigation, but certainly I think many of us are considering that approach in treatment. Well, I actually tend to be a lumper rather than a splitter. I like to keep it simple. And my perspective on this is that despite the clear heterogeneity of patients who have this problem, perhaps there's another way to view this problem. I love this photograph of the late Robin Williams providing tissue paper to the thinker, understanding there could be another perspective of the same problem. And this was really made acute to me in an analysis we did with the Penn Heart Study and Tom Coppola and Nancy Schweitzer a number of years ago. And I was very interested at the time about what does happen to patients when their ejection fraction recovers, goes back to normal, arguably the kind of ejection fraction a HFpEF patient might have. And you'd think that with the recovery of ejection fraction and arguably the recovery of stroke volume and cardiac output, they should never have an event. Well, it turns out that patients, despite the recovery of ejection fraction, still have clinical events. And one of those clinical events is heart failure hospitalizations, as you can see on the right. And these heart failure hospitalizations are, of course, notoriously dominated by congestion. And so it begged the question, why were they still sodium and fluid avid, despite having recovery of cardiac functions, cardiac systolic function? Well, so this begs the question of the centrality of explaining congestion. And in fact, most of us as clinicians don't even consider, frankly, the diagnosis of heart failure until the patient requires a diuretic, whether that's in the hospital or in your office, and there's an improvement in clinical status. In almost every modern day heart failure trial in this space of HFpEF will require signs and symptoms of congestion, whether that is at the bedside or by laboratory, e.g. the elevation of a natriuretic peptide, a heart failure hospitalization, or the like. I put up on the screen simply the TOPCAT inclusion criteria, and we were very active in this trial a number of years ago. So I'd like to explore this dilemma that has bothered me for many years, and that is, what is the stimulus for salt and water? And perhaps this homogeneity across HFpEF subtypes, if explained, could be a target for treatment and prevention. So here goes. HFpEF really largely remains unexplained. There are multiple observations that have suggested heterogeneity and multiple mechanisms at hand, including things like bradycardia, lack of vasodilatory reserve, even systolic dysfunction. Regardless of mechanism, though, as I've already outlined, heart failure with preserved ejection fraction fundamentally is defined by the clinical consequences of volume overload, heart failure hospitalizations. Yet, and I'm not a nephrologist, but as a cardiologist, what I'd like to know is, what is the fundamental cause of sodium fluid overload? Well, heart failure as a paradigm has always been based upon the central role of neurohormonal activation. Some sort of myocardial injury results in a fall in ventricular performance, which then leads to activation of the renin-angiotensin system, as well as sympathetic nervous systems and other cytokine and hormonal pathways. And activation of these pathways lead not only to direct myocardial toxicity and remodeling, but result in sodium and fluid avidity to the kidney, and you end up with edema, weight gain, shortness of breath, and often hospitalization. And this, of course, is the paradigm we use for HFrEF, or systolic heart failure. Well, can we make a case that this is the same operational construct for HFpEF? If so, then we should be able to identify these three problems present in a cohort of patients with HFpEF. Number one, there should be some cardiovascular stimulus for neurohormonal activation, right? There should be some abnormality of the heart that's related to the kidney, usually that's cardiac output or vascular resistance, that might put into play and stimulate neurohormonal pathways. Number two, we should be able to find evidence of this activation. And number three, it just follows that if you block it, outcomes should be better. And certainly we've done that in HFrEF. So let's take these one by one in the world of HFpEF. So there are a lot of data sets out there looking at invasive hemodynamics in HFpEF patients. Most of them are single center research-based studies. This is one from Barry Borlaug's lab, in which HFpEF patients on the far right are compared to control patients and hypertensive controls in the middle. And you see a number of hemodynamic characterizations on the far left. What I'd like you to pay attention to is the very last row, which is the cardiac index. And as you can see, at least at rest, there is no difference at rest between HFpEF patients, hypertensive controls, or other non-hypertensive controls. These are not patients who have inappropriate vasoplegia either. If you look at SVRI in the third row, the systemic vascular resistance indexed here, again, no difference across the three cohorts. So it's been very difficult to show that there is a cardiovascular stimulus for saltwater retention. Number two, we talked about the fact that there should be evidence for neurohormonal activation. This has been exceedingly difficult to do. In fact, I can only find two and a half, because one of those are our series in a very small group of patients, that speak to this issue of neurohormonal activation. This is work from John McMurray in the SOLVE data set, which you can see here with HFpEF patients on the in the middle column and HFrEF patients on the far right, that compared to controls on the far left, that yeah, there does appear to be sympathetic nervous system activation, adrenergic activation by measuring plasma and norepinephrine levels, and then RAS system activation by measuring plasma renin. But when you compare the middle bar, which is the HFpEF patients, with the control bar on the far left, I would venture to say those aren't too dissimilar. There are very few, well, there are no randomized prospective clinical trials of beta blockade in HFpEF per se, but there are some observational data that suggests that blockade of the adrenergic system does not appear to improve outcomes. This is work from Lars Lund from the Swedish heart failure cohort, and if you looked at the matched cohort there in the dark lines, you can see that there's really no difference in outcome in patients who are on beta blocker versus not on beta blocker who are suffering from HFpEF. With respect to the renin-angiotensin system, we also know that attempts to block renin-angiotensin system activation have not generally been positive. This is work from the iPreserve prospective trial of the ARB irbesartan versus placebo in a group of HFpEF patients. This trial was neutral. It did not improve the combined outcome of heart failure hospitalizations or cardiovascular death. And if you look at the specific clinical outcome related to congestion, hospitalization for worsening heart failure, you can see it was a complete wash. Absolutely no difference in this particular outcome. And no matter how you slice it, try to find patients who, for example, were either on RAS antagonists before they entered the trial or not, whether you looked at background beta blocker therapy, the presence or absence of diabetes, even previously having an episode of congestion with a heart failure hospitalization, or where you were in the world, not a single subgroup appeared to benefit from this intervention. And then finally, unlike the story with HFrEF, or heart failure with reduced ejection fraction, where bumps in creatinine actually are a marker of response to therapy over time, we see just the opposite here. This is actually looking at ARB use in the irbesartan trial, and you can see that those patients who had worsening renal function on irbesartan over time had a worse prognosis, and perhaps the ARB was uncovering a subtle abnormality in renal function that portended the poor outcome. So again, it begs this question: is HFpEF heart failure in the traditional sense? I borrowed this cartoon from Barry Borlaug and Maggie Redfield, which illustrates the differences between HFrEF and HFpEF with respect to neurohormonal activation. You can see in blue that those patients with HFrEF clearly are improved by antagonism of neurohormonal pathways, but in HFpEF it's pretty much been a bust. Well, then, is this simply a syndrome of volume overload, and the heart is somewhat an innocent bystander in this whole business? I borrowed this slide from Bob Schreier and Bill Abraham from a review in the New England Journal more than a decade ago that looked at the mechanisms of congestion and cardiorenal syndrome. And I put this up because we have a lot of biases as cardiologists. And you can see all of these arrows actually point to the kidney. None of them point away from the kidney. And it's often said that the kidney simply is just a barometer of what's going on, and it's really just playing a passive role in the environment. And it goes to some of our leading authorities. This is a quote from a very good friend of mine who wrote the chapter in our major textbook of cardiology, and this is directly quoted out of the chapter about heart failure. And the quote is, "There is little evidence to suggest that a primary renal abnormality is responsible for excessive sodium retention in heart failure." So boy, the deck is really stacked against consideration of this perhaps central role of the kidney in HFpEF. So what am I going to try to make the case for in the next 20 minutes? Well, if sodium and fluid avidity or a lack of excreting sodium and fluid appropriately is not being driven by neurohormonal stimulation, which was driven by cardiac dysfunction, then perhaps the kidney must be doing so inappropriately, e.g., that perhaps the problem resides in the kidney. Well, these are the 5 points I'm going to try to make as circumstantial evidence that perhaps HFpEF should not be called heart failure, but rather a renal failure. Number one, renal insufficiency is common in HFpEF and independently as associated with outcomes, much like it is in HFrEF. I think there are very few people, I think, that would find that a controversial statement, but we'll very quickly explore this. Number two, renal function is inadequately characterized by measures of glomerular filtration. This is really important because I'm often told, well, the creatinine and eGFR are normal or in a normal range. You know, that must mean kidney function is normal. Well, I think we all know it's a little bit more complicated than that. And these subtle abnormalities, I think, are really important to characterize. For example, tubular function is instrumental in managing salt and fluid handling by the kidney, but we rarely explore tubular function in clinical practice. Number three, it's important to recognize that if in fact the kidney is the issue, we should have data sets that would suggest that renal insufficiency would presage HFpEF. Number four, that don't forget, renal insufficiency can certainly mediate cardiovascular dysfunction. We all know this, taking care of dialysis patients and other patients with other levels of severity of CKD. But then I'd also like to drive home a point that we probably don't talk about much, and the importance of keeping somebody dry or euvolemic. That salt and water overload in and of itself is a cardiovascular and renal insult that is self-perpetuating and if manageable, can improve the outcome in these patients. So let's take point number one, that CKD independently is associated with outcomes in HFpEF. This is a large data set gleaned from a number of health system data sets, Kaiser and others. And as you can see here, that is GFR falls, that the risk for HFpEF and HFrEF on the far right increases and in a like manner. Let's move on to point number two, that renal function is inadequately characterized by measures of glomerular filtration. This was really borne out, I think, from a clinical trials point of view by this data from the GISI-HF trial. And in this particular study, they were able to segregate outcomes in this large data set, looking at not only markers of glomerular function, albuminuria and GFR, but also by measuring tubular biomarkers such as NAG and GAL-KIM1. As you can see here, that when you introduce tubular interstitial biomarkers to give the measurement of renal function a little bit more fidelity, that in fact you do see patients who in fact have poor outcomes that are not evident from the GFR or the serum creatinine. From a physiologic point of view, we've known this for some time. Now this is a HFrEF study. These are patients with systolic heart failure, but I think the point is the same, and we're going to get to a little bit about our experience. You can see here, this is a small group of patients that were studied with normal controls. In black are the mild heart failure patients, the clear bars are the normal subjects. And you can see that after a week or two of high sodium loading that GFR increases and renal blood flow increases due to the increased plasma volume. And similarly, renal vascular resistance falls. What's really fascinating though, that despite the same GFR and changes in GFR in these patients, that sodium and water handling are clearly different. In the upper panels, you can see that the filtration of sodium, again, is quite high due to the increased plasma volume. But when you look at the clearance of water, the excretion of potassium as a measure of distal tubular function, and the excretion of sodium, as you can see at the very bottom, patients with HFrEF behave very differently and, in fact, cannot and don't excrete the water and sodium appropriately. And therefore, again, that measures of renal dysfunction are often not visible to us at the bedside, and I think often underappreciated in many of our patients. We have recapitulated some of this work in HFpEF patients. This is some work we've done here with a group of 10 HFpEF patients and 5 controls in a very similar protocol, where they came in, we gave them a saline infusion, and then looked at what happened to their sodium and fluid excretion. And perhaps no big surprise that when you give them this sodium load, that normal controls get rid of it, but the HFpEF patients don't. And in fact, this results in a positive fluid balance in the HFpEF patients, but not in the controls. We're doing a number of other analyses, looking at specific proteins in the urine as well as the serum, and trying to tease out in a more mechanistic way what exactly is the issue. Well, is there evidence that renal insufficiency can presage HFpEF? Well, there are animal models, which I think are very important. It's always a little bit of a date in the world of HFpEF, which is the best animal model to use, whether you should use mice or rats or large animals. I like this particular one because it is a large animal. It's a pig, and this is an approach used by Josh Hare recently at Miami to look at the impact of GHRH to improve outcomes in a HFpEF pig model. And these pigs, pig patients, underwent a subtotal nephrectomy by embolizing a portion of one of the kidneys to produce a CKD model. And this is, I think, reasonably well accepted in the renal literature as a model, albeit probably not perfect for the human paradigm, but certainly one that's often used experimentally. And as you can see in the table in the upper right, these patients become hypertensive, they do have renal insufficiency, and even anemia. And when you characterize the cardiac abnormalities, you can see that these are all consistent with patients with HFpEF, with an increase in diastolic pressure, changes in the PVR, and relaxation. There are also prospective epidemiologic data sets that also, I think, provide support to the idea that renal dysfunction is a clinical risk factor for incident HFpEF, in contrast to HFrEF. This is work from the PREVEND registry of some 8,600 patients in the Netherlands, followed for a decade, who span the ages of 28 to 75 with very modest levels of urinary albumin excretion. And as you can see here, that I've highlighted for you in the middle 2 rows, having elevations in cystatin C or significant urinary albumin excretion portended the development of HFpEF, in contrast to a lack of impact on those patients who were ultimately to develop HFrEF. Well, can renal insufficiency in and of itself affect cardiac function? I think, again, here, this is no surprise, but just to go over this, yes. In HFpEF patients, for example, you can see that there is a stepwise relationship between worsening renal function and left atrial function. You can do this also with LV mass. You can do this with left atrial size, etc. So this association too, I think, has also been borne out by vascular studies. I think all of us recognize as well that patients who have CKD have stiffer arteries. If you look at the left, what you see here is the relationship of worsening eGFR with compliance measured along the y-axis, and those patients with increasing levels of urinary albumin associated with less compliance. It can be also measured using pulse wave velocity. The higher the pulse wave velocity, the stiffer the blood vessel. And as you can see here, that as CKD stages increase, blood vessels get stiffer, and this is amplified by the presence of diabetes. What's another potential mediator of this? Well, there are a number of proteins that have been explored. This is a small list. There are a number of very large-scale proteomic studies that are going on in CKD that are looking for novel proteins that could be targeted. But likely this is a multifactorial issue, and it will be interesting whether or not there will be an identifiable smoking gun, so to speak, that might help to explain the cardiac dysfunction in patients with CKD, but stay tuned. Well, let's go over some other final concepts here. This one is the issue of sodium and water overload as a cardiovascular insult in and of itself. And this also, I think, is really critical because this helps to explain sort of the vicious cycle of volume and sodium retention in heart failure syndromes and HFpEF in particular. There are many deleterious consequences of sodium and water overload. And this has been borne out in a number of studies. These abnormal sequelae include diffuse inflammation, oxidative stress, back pressure on the kidney. I think we all recognize the importance of high CVP and renal vein pressure to renal dysfunction. Don't forget, a overfilled vascular tree is going to be a stiffer vascular tree, not only resulting in stiffer arteries, but hypertension as well. And of course, it's a pretty strong stimulus for adrenergic activity. One of the things about heart failure and venous congestion is that don't forget that the veins are a very important source of endothelial function, and that distension of this compartment, vascular compartment, is really, really important. Keep in mind that most of our blood volume and plasma volume sits in the veins, and when this volume becomes stressed, there are abnormalities that follow, including inflammation and endothelial activation. So this is a really clever study done by NEUROHORMONAL in Colombia, in whom they took normal volunteers. These were patients that I think were an average age of 35, 40, and simply looked at what happened if you put up a tourniquet and engorged the forearm. And what he did was measure a number of markers before and after putting up this tourniquet for 75 minutes. And as you can see here, that there were increases in inflammatory markers, interleukin-6, TNF-alpha, endothelin-1, angiotensin-2, and markers of endothelial dysfunction as characterized by increases in VCAM expression. So just the distension of our vascular tree is a significant systemic insult. Moreover, this sodium overload also leads to hyperfiltration and glomerular sclerosis. This is a very interesting rat model, nephrectomized rat model, to highlight what happens to the glomerulus with a high salt diet. You can see that in the animals that were nephrectomized and given a high salt diet, in the pink middle bottom panel, the glomerulus becomes scarred and shrunken. And this phenotype can be attenuated by giving idapamide. again, circumstantial evidence that the salt overload was contributing to the glomerular sclerosis. Well, what are the therapeutic implications at the end of the day? This is medical grand rounds, and people are probably saying, well, what do we do at the end of the day with this problem? To say control sodium and fluid avidity just seems so obvious, but I do think there are some important observations to make in your clinical practice with how important this is. Number two, obviously targeting the kidney. I think this is now ready for prime time. There are interventions we can do to help slow the progression of renal dysfunction. And then finally, I'm going to make a couple of comments about my perspective on the cardio. And that is not really so much an issue of the organs themselves, but the neighborhood that they live in. So salt restriction. This is a study from Scott Hummel from Michigan, who took a group of patients, I think they're 12, 14 patients who had been hospitalized with HFpEF, and subjected them to 3 weeks of a DASH diet. Pretty strict sodium controls, you can see there, 1150 milligrams daily. And then he simply examined their blood pressures, their vascular stiffness, and oxidant stress before and after. And as you can see, that with this strict sodium diet, that there was an improvement in both blood pressure in the office and at home. Carotid ephemeral pulse wave velocity decreased as a demonstration of improved vascular compliance and decrease in stiffening, and that there was a reduction in oxidant stresses measured by urinary isoprostanes. Number two, we've recognized from other clinical data sets and clinical trials that controlling salt and volume retention before it's clinically evident can keep people out of trouble. This is work from the CardioMEMS clinical trial where 119 of the 550 patients in this randomized study of an implantable device to measure PA pressures could be used to manage patients, essentially diuretics, over the course of a couple of years. And as you can see here, that if you manage patients' volume status before perhaps they're symptomatic, that you can keep people out of the hospital. We demonstrated from the TOPCAT trial in a post-hoc analysis that spironolactone, which don't forget is a diuretic, does appear to also attenuate the need over time for more diuretics. And again, another shout out to managing salt and volume retention in these patients. You can see this best illustrated in the graph in the lower right-hand column, where you see the spironolactone arm in the red and the placebo arm in the blue. And this was both resulting, as you can see in the upper left-hand panel, a stable decline in body weight over time that was comparable. It's important to recognize that loop diuretics also appear to improve vascular stiffness better than the other drug classes. This is work from Bill Cushman from years ago at UAB that looked at the impact of hydrochlorothiazide versus other blood pressure medications with respect to reduction in the pulse pressure, again, as a very crude way of measuring vascular stiffness. As you can see here, that those patients who are getting hydrochlorothiazide were much more likely to have a reduction in pulse pressure to less than 50 millimeters of mercury. And then finally, in the ALL-HAT trial, one of the largest hypertensive trials ever done, demonstrated that the diuretic chlorthalidone appeared to particularly have an impact on incident HFpEF in contrast to HFrEF. You'll recall this is a very large trial of more than 20,000 patients randomized to chlorthalidone, lisinopril, amlodipine, or prazosin for the management of their hypertension. And you'll recall that in this particular trial, prazosin was actually stopped early because there was an excess in heart failure. But what was really interesting, again, as you can see in the panel on the left, that chlorthalidone relative to lisinopril and amlodipine did appear to reduce incident HFpEF. And in contrast, both chlorthalidone and lisinopril were able to reduce incident HFrEF, suggesting again two very different pathophysiologic features of these two disorders. Well, finally, we're now in an era where addressing CKD and trying to prevent or slow its progression is really here, and I believe here to stay. When we looked at the TOPCAT trial, we saw that those patients, particularly with albuminuria as a subtle evidence of renal dysfunction, were particularly benefited from spironolactone. What we found that spironolactone appeared to reduce albuminuria by 39%, again suggesting that it was having some benefit on the kidney specifically. Number two, there was the effect was larger with greater degrees of baseline albuminuria. Reducing the albuminuria and renal function and improving the renal function did correspond to a greater reduction in heart failure hospitalization and all-cause mortality, and this effect could not be explained entirely by changes in blood pressure. This, of course, has even gone one step further with this new class of MRA, finerenone, which is a non-steroidal MRA that appears to be associated with less hyperkalemia and much more specific for the MRA receptor. And this is one of two trials that made a big splash in the New England Journal. And these were the Fidelio and Figaro DKD trials, where they took patients with albuminuric CKD and type 2 diabetes and randomized them to this MRA versus placebo. And in Fidelio, the primary outcome was a renal outcome. In the companion trial of Figaro, the primary outcome was cardiovascular. And again, perhaps it's no big surprise, using this agent to improve renal outcomes also happened to improve cardiovascular outcomes, with a reduction of almost 20% in the combined endpoint of CV death and first heart failure hospitalization, and driven to a large extent by a reduction in first heart failure hospitalization by almost 30%, as you can see in the very bottom row. And again, very well tolerated with very low hyperkalemic rates relative to placebo. And we should keep in mind, too, that other interventions have also improved, which appear to improve the outcomes of patients with HFpEF, also appear to improve the outcomes in the kidney. This is the Paragon trial, which is a trial of sacubitril valsartan in HFpEF compared to an active treatment. Valsartan, and as you can see here, that this p-value of 0.06, which was not technically statistically significant, did impress the FDA and has now been approved for the management of HFpEF. But importantly, you should be recognized that although there was no impact on cardiovascular total mortality, there was an improvement in the renal composite outcome. And to conclude, I think we have to talk about sodium glucose cotransporter type 2 inhibitors. Dr. Braunwald recently commented these are the statins of heart failure, very well tolerated and have a profound impact across the board and across ejection fractions. Now, these drugs have a lot of putative mechanisms. You certainly can't use a clinical trial to tell you how a drug is working, but it's very important to recognize that they do provide a natriuresis and arguably are a perfect diuretic. They result in a reduction in plasma volume, at least acutely. They do not result in neurohormonal activation, unlike loop diuretics. And there are very few electrolyte changes. In fact, uric acid and magnesium improve with this intervention. And the reason I'm highlighting these set of drugs is because they are targeting the kidney. Although there are many putative mechanisms, it's hard to debate that this drug was designed to prevent glucose reuptake in the proximal tubular, and that's where the majority of sodium glucose cotransporters sit. And because of its cotransport with sodium, we see natriuresis. And so again, this idea of targeting the kidney and therefore the systemic milieu may improve outcomes. And this was, of course, brought to light in the clinical trial, Emperor Preserved, in which patients with very mild HFpEF were randomized to empagliflozin versus placebo. You can see here that the patients were older, roughly half were women. The NT-proBNP was about 1,000. The eGFR was right at the cutoff of stage 3 CKD. And as you can see, these curves separate early, that the reduction is of approximately 20%, largely driven by a 30% reduction in heart failure hospitalization. And importantly, that was also an improvement by attenuating the decline in renal function over time using an eGFR slope to quantify this. But I do want to highlight that these interventions have been primarily targeting congestion. Whether you look at Emperor Preserved or Paragon HF, you can see here that the impact across ejection fractions are geared toward congestion and heart failure hospitalizations, as you can see in the upper right panel and the lower left-hand panel. Cardiovascular mortality per se and all-cause mortality have not been affected, as illustrated with respect to cardiovascular mortality by the figure in the lower right-hand column, in the lower right-hand of this slide. So, it really begs the question, are we really just dealing with an issue of congestion and preventing congestion? And then finally, the last thing to do is to consider HFpEF as perhaps one of the most dramatic paradigms of cardiorenal syndrome, where the issue isn't the problem of the kidney being bad affecting the heart, or the heart being bad and affecting the kidney, but it's the neighborhood that they live in. That the dysfunction of the kidney and the heart are occurring in somewhat independent of one another because of the systemic milieu of inflammation and oxidant stress driven by comorbidities, genetic influences, even gender. And although the kidney and heart communicate via a number of pathways, including vascular, bloodborne, and autonomic means, that it's this highly disturbed systemic milieu that is driving the dysfunction of both organs at the same time and to some degree independently. And if we can improve the neighborhood or the milieu, perhaps we can see a reduction in heart failure outcomes as well as an improvement in renal outcomes. And this was illustrated in the CANTOS trial, where the use of a monoclonal antibody against IL-1 beta in a post-hoc analysis was associated with a reduction in heart failure hospitalizations in a dose-dependent way. So my personal bias is that HFpEF is less an issue of the heart being affected than it is the kidney being affected, leading to congestion and heart failure hospitalization and exertional intolerance. And although we see patients with cardiogenic shock on the far left, in which the problem is clearly cardiac output, and we see patients on the far right in which the kidney is dead, most of what we do in the middle. And that the primary role of the kidney driving salt and fluid retention and leading to this vicious cycle of vascular dysfunction, promoting further inflammation and oxidant stress in this environment, leads to further dysfunction of both organs, and then ultimately a hospitalization or mortality. So I think it's time to perhaps rethink HFpEF as not a heart failure problem, but as a renal problem, and that in collaboration with our nephrology and other colleagues, that we can crack this nut by taking a more holistic 30,000-foot view. So to summarize, the cause of volume overload in HFpEF remains unclear. In contrast to HFrEF, neurohormonal activation is not universal. Certainly antagonizing neurohormonal pathways has not generally improved outcomes. Volume overload, therefore, may be a consequence of a primary renal disorder that may not be as clinically apparent to us at the bedside, and that HFpEF may be the result of a renal cardiac vicious cycle, and that I do think we're here now at a time where targeting the kidney is a relevant strategic way forward. And of course, I'd like to thank my division who allows me the time to come speak with you. Again, I'd love to be in Seattle with you rather than virtually, but these are the times. And I'd also invite you to ski if we only had more snow. So thank you very much.
That was great. Thank you so much, Dr. Fang. I'd like to just open it up to questions. We have a few minutes here. So if you do have questions, please feel free to submit them. And I'll just read a couple that we have coming in. So Dr. Bomstick is saying virtually every disease is a systemic syndrome. HFpEF seems to not be an exception. Certainly seems to be the case. We have a comment and a question here from one of our nephrologists saying he was interested in glomerular hyperfiltration, particularly in diabetic patients. He had proposed that a defect in proximal tubular sodium absorption might be responsible, hoping that inhibitors of sodium glucose cotransport might impact the development of renal disease. Is this likewise to be a contributor to heart failure? I know you were alluding to some of that, but I'll let you respond.
Sure. I think the person who asked the question was asking about mechanism. Why do sodium glucose cotransporter type 2 inhibitors prevent the progression of CKD? And yeah, there is some evidence that it actually decreases glomerular pressure by vasoconstricting the afferent limb, and therefore preventing high glomerular pressures and hyperfiltration. This is pretty, I think, reasonably well worked out in diabetes. This is why we use ACE inhibitors and ARBs, right, to address the efferent limb, not the afferent limb. But this is probably one reason why SGLT2 inhibitors prevent the progression of CKD by producing afferent vasoconstriction and reducing hyperfiltration and glomerular pressure.
Another question we have is that one common challenge is diagnosing HFpEF in patients with CKD, particularly stage 3 and 4, when they have left ventricular hypertrophy, and the symptoms of heart failure and CKD seem to overlap. Do you think we need different diagnostic criteria for HFpEF in patients with CKD in particular?
Yeah, that's a great question. Who hasn't seen somebody short of breath, obese, right, with a creatinine of 2? And you're like, is this heart failure? Or is this just obesity? Or is it? So, it's a great question. Fundamentally, I think as clinicians, there has to be some evidence for congestion before we call it heart failure. We do bring them to the cath lab, and we do look for exertional increases in filling pressures. So if you have a patient who's short of breath and you can demonstrate that there is actually either some resting or provocable increase in filling pressures, that would make the diagnosis of heart failure. Giving a patient diuretics and relieving congestion, I think, is pretty good evidence the patient had heart failure. Certainly seeing left atrial enlargement and pulmonary hypertension on the echo are also highly suggestive in a patient with CKD who's short of breath. And then finally, of course, is the gold standard: bring them to the cath lab and see if there is either spontaneous or provocable elevations in filling pressures. Great.
And I think we maybe have time for one more question. Another question that came in asks, is there any part of this presentation that would not apply to the course or treatment of idiopathic pulmonary hypertension?
Oh, yeah. Good question. Yeah, so that's a really important clinical pearl, is that if you're going to say somebody has idiopathic pulmonary hypertension, you better be able to prove to me that the LVEDP was low. And you cannot do that on an echo. And so these comments, whether they are applied to patients with PAH, remain unknown. Most of this is really centered around patients with left ventricular causes of heart failure per se, whether it's induced by the kidney or not. We do not know, actually, in patients with right heart failure due to PAH, whether these interventions work. It's always a big debate. For example, do you put patients with right heart failure from PAH on ACE inhibitors, ARBs, beta blockers? There's very little evidence, actually, that those interventions work in the syndrome of pure right heart failure independent of left heart failure.
All right. Well, we're coming up right on the hour here at 1 o'clock. I want to be mindful of your time, but thank you so much to everyone who participated and joined us today. And thank you, Dr. Fang, for a great lecture.
Thank you for inviting me. Have a great weekend, TGIF.